for session 2, allow me to talk a little bit about it. Session 2 is on acne and rosacea. And also we have 4 speakers, Dr. Michael Gold from the USA, Dr. Irma Bernadette from Indonesia, and Professor Dae-Hoon Soon from South Korea, and myself. And I would like to introduce our first speaker. Actually, he already gave a preliminary talk in the first session. Dr. Michael Gold. Can we have the biodata of Dr. Michael Gold? Okay, Dr. Michael Gold is the founder and medical director of Gold Skin Care Center, Advanced Aesthetics Medical Spa, the Laser and Rejuvenation Center, and Tennessee Clinical Research Center in Nashville, Tennessee. Dr. Gold has earned worldwide recognition for providing patients with leading-edge technological advances in dermatology and aesthetic skincare. He plays an integral role in the development of new pharmaceutical products, injectable fillers and toxins, skincare, and medical devices through his clinical research. The title of his lecture is Acne Therapy with EBDs in Skin of Color. Dr. Michael Gold, you can have the floor.
Hi, everybody. This is Dr. Michael Gold, and I am privileged to be at the E-Asia Derma 2021 meeting. I am a dermatologist from Nashville, Tennessee. This talk is Acne Therapies with EBDs and Skin of Color. I am a dermatologist. As I mentioned, these are my academic appointments. I am also the editor-in-chief of the Journal of Cosmetic Dermatology and Dermatologic Reviews. These are my relevant disclosures for this talk. So as a dermatologist, acne is a very important disease that we see every day. It's perhaps the most common thing we see in our clinics. More than 80% of adolescents and over 40% of adults over the age of 25 suffer from acne. It is associated with disfigurement, pain, loss of confidence, and depression, and it very severely affects our quality of life. One of the things we've all noted is that acne is an undertreated disease. By the time many come to us as dermatologists, they have seen other providers. They've done things from the pharmacy or other over-the-counter methods. And again, we see them when they really need our care. Traditionally, we diagnose, we prescribe, and we wait and see. This is a method that has been used for years. And again, in today's world, people want to get better quickly. But if you look at the Global Alliance Acne Treatment algorithm, which has great ideas for medicines, things like lasers and energy-based devices are not there. So patients and physicians need a more effective, more predictable, cost-effective, cost-efficient approach to addressing acne in the modern patient. So we're going to cover lasers and IPLs that can be used for the treatment of acne. We cannot cover everything related to acne scars. We'll go over just a little bit. But if you have somebody with active acne and acne scars, you can actually treat the active acne while you're treating the scars. So this device is the Fractura from InMode. It is a microneedling device with or without insulation. And again, when you treat these patients for their active acne or their acne scars, the active acne gets better, as seen here. Another patient here with active acne and scarring, both improve. They now have a new device called the Morpheus 8, which is a deeper penetrating microneedling system, part of all their workstations. And Bruce Katz in 2019 published a very nice article looking at this device with active acne and acne scars, showing some very nice results. I've been talking about using energy-based devices for a long time. This is a paper I wrote in 2006 to give people an idea that this is a viable option and continues to be to this day. David Goldberg and Bradley Bloom in 2016 published a very nice review of energy-based devices in derm surgery, which will work to show some of the charts that from their article in this talk, such as this one. Again, looking at the various devices, the wavelengths of the energy emitted, whether it's IPL, blue light, red light, PDL, KTP, the mechanism of action, whether it's destroying the P or C acnes, how it works. They're destroying the sebaceous gland and the efficacies that you can see with this. So we really work with 3 different methods here. We can destroy the P or C acnes with the devices listed. We can destroy the sebaceous gland, or we can just work on the vascular supply to that sebaceous gland. So we'll start with the lasers that destroy the P or C acnes population. They include the blue and red lights, the intense pulse lights, the vascular lasers, and the short pulse 1064 devices. When we talk about blue and red light, phototherapy works through the process of photoexcitation of the P acnes porphyrins after exposure of an appropriate wavelength of light. This leads to the formation of singlet oxygen within the bacteria and ultimate destruction of the P. acnes bacteria. The acne lesions resolve, leaving alone surrounding tissue and structures. Again, many studies have been published over the years looking at blue light, red light, topical with these, and again, some very nice results that you can see in a series of patients. These are some of my patients that were treated. Usually we treat these patients twice a week for 4 weeks. This is a poster that we presented in 2003 at the American Academy of Dermatology. We then published a paper comparing this with 1% clindamycin. I did this with Mitch Goldman and Jaggi Rao. Blue light worked better. Again, this was published. This is one of the examples of the blue lights in the United States. The IPLs are many, numerous. They've been reported since 2002. Vic Ross, 50% inflammatory acne improvement. Monica Ellman and Joseph Ledsetter in Durham surgery in 2004. 85% of the patients had over 50% improvement. And again, when you look at the various studies that have been done, there have been lots studied, lots published, some very nice clinical results as a result. This is the Stellar IPL from Luminous. Again, very nice multi-platform device. And what you notice here is an acne filter, which is very important because this is a special acne notch filter working between 400 and 600 and 800 and 1200 nanometers. This 400 to 600 corresponds with the Soret peak sort band of porphyrins, and 800 and 1200 actually works on the sebaceous glands. So Dr. Wanhong Li from Shenyang, China showed some very nice clinical results using this IPL. This is the acne notch filter. You see the improvements here in a series of patients. Cyton makes a broadband light source. Again, very sophisticated, very nice IPL. Their new device is called the BBL Hero. Again, as I said, works very nicely, as you see here, in a group of patients treated with acne. This is one of my just telangiectatic patients, but the BBL Hero is a new in-motion IPL, allowing you to get these kind of effects in photo damage. The Lumeka makes a IPL which works with 2 wavelengths, 515 to 1200 and 580 to 1200. More laser-like, very efficient in its absorption, with a very, again, sophisticated IPL. As you see here, the improvement in your inflammatory acne. Solta makes the Isolase. This is a really fascinating vacuum apparatus device, IPL, not really available anymore, but I still think one of the best devices that we've ever had for acne. It uses this vacuum to sort of cleanse the skin by taking the tissue into the vacuum, purifying it with broadband light. There's a replenish or perfusion tip, and then the area is released into the skin. We wrote about this back in 2008, looking at 11 patients, and again, with an 80% reduction in inflammatory lesions, a 60% reduction in non-inflammatory lesions in a series of patients that we treated. Again, some very nice results. Infrared lasers work either, as I said, by targeting the 1320, 1319 area, or destruction of the sebaceous glands from 1450, which is really not used very much today because of the pain associated with it. This is a new device, the Adva TX. It's a 589 1319 ND-YAG that actually, with a single scanning handpiece, both wavelengths delivered through that. The 589 can be used as any 589 nanometer laser would. The 1319, again, for improvement in inflammatory acne, improvements of the pores, reduction of acne scars. So here's some patients that were treated. One of my patients were treated with not only the active acne, but the acne scarring. Again, this is a study we just did looking at the ECCA, which is a validated acne scarring scale, a series of patients with scars and some active acne. This improved. We published this in 2019. Just some more examples shown here of inflammatory acne. Aerolase makes the short pulse 1064, 650 microsecond, 1064 nanometer laser. It's contact free, which I like in this environment. It's virtually painless in our patients. And Mark Nestor, David Goldberg, and I published about this device in 2017. Again, some examples from my practice of some significant acne, different skin types. It works in all skin colors, which is really nice. We can get some very significant results. This Indian patient who had failed 4 courses of isotretinoin, we treated her 6 times. You can see the improvement here. 1 year later, it's a very significant improvement in her active acne. David Goldberg looked at this device compared to a sham device. You see a remarkable improvement versus the sham with about a 40% reduction in inflammatory lesions and 20% reduction in sebum. And in 2020, we published with a group from Russia the use of this device in patients that were taking low-dose isotretinoin, as shown here. These are the incredible investigators from Russia. I thank them for letting me help them here. The IGA improved significantly. The quality of life improved significantly. And again, the patient's response to this device when they were on low-dose isotretinoin was just truly remarkable, and something to consider in your patients that have significant, severe acne and acne scarring, that you can really change their life. So photodynamic therapy has been written about for a long time, whether it's ALA, methyl ALA, both work very nicely for acne. Here's a list of all the prevalent studies that have been done with this material. Rox Anderson and Wichai Hangzhu published the first paper back in 2000. They had significant clearance with a 3-hour occluded ALA and a broadband light source, but they did have a significant, what we call the PDT effect, erythema, edema, and crusting, plus transient hyperpigmentation. This is somebody's back, and you see the improvement here. And when you looked at the fluorescence and the histology, so the ALA gets into the sebaceous gland, and then there's a partial destruction of that gland. Again, I mentioned that there have been plenty of studies with this. These are, again, just a list of the clinical studies and several split-face IPL studies that have been done. Again, some clinical photographs before and after, whether these patients were treated with ALA and either a blue light or an IPL or various other systems. You see the improvement here. This is a pulse dyed laser. This is a Ktp laser. This is a IPL split, part of the split face studies that were done, and just some other examples from my clinic of people who were treated with severe acne. And again, you see the remarkable improvement. Again, this was an IPL improvement, and this is Henry Chan's patient from Hong Kong. But you notice here, there's not much improvement after 3 treatments, but 7 weeks after that 3rd treatment, you see the improvement here. This is 1 treatment from a Korean patient. You see here, this is the one on the right is 5 months past 1 treatment, and here's 2 years later, and one of Mark Nestor's patients here 5 years later with improvement. So in the US, we've actually had 2 phase 2 clinical studies to look for significance of this, of ALA and blue light compared to blue light alone. And unfortunately, we were never able to show significance. So we do not have this as an FDA indication, although we all know this works really, really well. So again, acne therapy with lasers and EBD can make your acne patients better and faster compared to conventional therapy. Use these tools to help make your patients better in each and every day. I thank you. And again, I look forward to being with you, hopefully in 2022. Thank you very much.
Thank you very much for a wonderful lecture, Dr. Gold. Professor Soon. Professor Soon. Hi, Professor. Could you please introduce our next two speakers? Professor Su? Okay. There. Professor, could you please introduce our next two speakers? I give the floor to you. Professor, we cannot hear you.
Can you hear me?
Yes, now. Please
Okay.
introduce our next two speakers.
Yeah, it was my mistake. I should have pressed one button, but I did not. I'm very sorry about that.
It's okay, sir. It's okay, Professor.
Yeah. The next speaker is Dr. Omar Bernadette, as Shito Hang from Indonesia. Actually, I met her several times in Indonesia, and she is very famous dermatologist. She is currently the head of cosmetic dermatology division of Department of Dermatology Venereology, University of Indonesia. Dr. Shipto Mangunkusumo Hospital. She has been invited many international meetings, and she has many publications in peer-reviewed journals. She will speak about considerations of various adjuvant modalities in acne management today. So please. Okay, please start the lecture from Dr. Omar Bernadette.
Thank you, Chairman and Co-Chair. I would like to thank the head of Asia Derma Committee. It's an honor for me to share my talk in this event. Today, my topic is considerations of various adjuvant modalities in acne management. My talking points are about the epidemiology and increasing antibiotic resistance in introduction, and then I will talk about treatment guideline of acne in Indonesia with various adjuvant modalities in acne management guideline in Indonesia. Acne vulgaris, or we know just as acne, is a chronic inflammatory disease of the pilosebaceous unit which correlates with increasing sebum secretion, affected about 9.4% worldwide population and one of top 8 diseases in the world. From a systematic review, it is reported that prevalence of acne ranges from 20 to 95%. This is top 10 diagnoses in 2017 to 2018, data from several dermatology and venereology education centers in Indonesia. As we know, the education center is the university base that has dermatology and venereology program. We can see here in 3 out of 5 centers, acne is one of the top 3 diseases. Even in Universitas Indonesia here, Jakarta, and Universitas Gadjah Mada, Yogyakarta, acne is the #1 diagnosis. As acne is one of the most common cases in our daily practice, so the update and standard of acne management is essential of our dermatologists. In general, treatment of acne is based on the degree of acne. For moderate and severe acne, we will give systemic antibiotic. The long-term use of oral antibiotic has become one of the main concern for clinicians regarding the increasing of bacterial resistance. This article reported a high level of resistance to tetracycline erythromycin, and also clindamycin. In this map figure here, we can see the studies by McDowell et al. And Giannopoulos et al. Had reported intercontinental spread of high-level resistance of this genotype. Sorry for using Bahasa. We have other English version in the next slide. Acne therapy guideline in Indonesia, seen with other acne guideline from the other country or region, is divided into first line treatment, second line treatment, and third line treatment based on the degree of acne. What I want to show here is we also put the various modalities as adjuvant treatment in acne therapy guideline in Indonesia. In our guideline, we make the diagnosis first. Of course, that is based on the patient's complaints and clinical findings. We diagnose the patient into mild acne, moderate, or severe, based on Lehman criteria. According to Lehman, patient with total lesion less than 30 is classified into mild acne, and moderate acne 30 to 125, and severe more than 125. Now, here is the chart of the guideline for acne therapy in Indonesia based on the classification of mild, moderate, and severe. As I mentioned before, we always use adjuvant modalities for acne patients. Here is various kind of adjuvant treatment in Indonesia. Adjuvant therapy are treatment added when main treatment given. We know that, consisting of Comedo extraction, intralesion steroid injection, chemical peeling, laser, and dermocosmetic. Now we can see here the adjuvant modalities that we gave to acne patients in Indonesia. Intralesion triamcinolone acetonide injection is widely used in around the world. Lee et al. In Journal of American Academy of Dermatology stated that in giving intralesion triamcinolone injection, it is supposed to done by following the yellow line, as seen in here, not by following the red line, which is passing the healthy skin. Injection mostly given to cysts in high percentage, inflamed papule, and pastels. Generally, the concentration used in 2.5 milligrams per milliliter, and most of the time we give the volume 0.05 milliliter. Comedo extraction. Comedo extraction is adjuvant modality in acne that has been reported since a long time. We see here the references have been published since 1964 and 1972. So Comedo extraction has been done for a long time. In Indonesia, we have done a study, not only doing Comedo extraction, but we extracted the whole acne lesion in moderate acne patients group. We call it acne lesion extraction. Then we compare them with oral doxycycline group. It is shown that group with acne lesion extraction has improvement that is statistically significant improvement compared to doxycycline within 6 weeks. Although we can see it began to improve from week 4, yeah, but it is not statistically significant. This patient came with severe acne vulgaris case. There are multiple nodules here. We decided to do acne lesion extraction. There is much improvement in week 4. This patient underwent intralesion in steroid injection and acne lesion extraction. This show improvement after 4 weeks, and this patient improving in 6 weeks. This is another type of adjuvant modalities. According to Dreylos, moisturizer in acne patient is moisturizer with non-comedogenic and non-acnogenic properties. The decision making is choosing moisturizer is important one, especially in reducing skin irritation in acne skin and in use of retinoic acid. This is a review from a meeting in acne therapy in Asians relating to using dermocosmetic as an adjuvant. It showed that moisturizer can lessen reactions such as skin dryness and stinging that were caused by acne treatment agent and also leads to improvement of tolerability or patient's compliance. A multi-center study in Indonesia has reported that in group of patients with moisturizer with ingredients, topical niacinamide plus antibacterial adhesive agents and zinc pyrrolidone carboxylic acid had a decrease of non-inflammation in just the first 2 weeks in non-inflammatory lesions. What about chemical peeling? Chemical peeling is also one of adjuvant modalities for acne therapy. Glycolic acid peels need neutralizer, which is done with weak base, such as sodium bicarbonate. In Indonesia, we have done a study with patients that had chemical peeling, which is neutralized by sodium bicarbonate, compared with water. Just right after neutralization process, the group with sodium bicarbonate has statistically significant higher in pain score compared to the water group. These patients treated with moisturizer and glycolic acid pills. We can see here a clear difference of outcomes in these patients. Phoebe laser is known as the choice of adjuvant therapy for acne, which targeted oxyhemoglobin that induce photothermolysis in blood vessels, especially show more effective in inflammatory lesions. This article reported using Phoebe laser plus salicylic acid pills in acne compared to salicylic acid only has a significant difference. This patient with acne and with psoriasis. At that time, there are some psoriasis lesion in her back. We didn't see here. We consider Phoebe laser in adjuvant therapy to first-line treatment in order to speed up and accelerate the reduction of erythema. So we decided that Phoebe laser is our choice. This is before, and this is 2 weeks after Phoebe laser treatment. Also for this patient had severe erythema, so we considered to do Phoebe laser. This is the result of second laser with 2 weeks interval. We can see the clinical improvement was very good. The erythema reduced markedly. Reflect in acne management. I think this is still a question mark, still challenging. Here, absorption spectrum of hemoglobin is still covered by the wavelength of this laser. So I had considered to try this laser. We see it is very satisfying. However, the mechanism of action is still unknown. Do we need anti-fungal treatment for acne patients? Sometimes in acne patients, we found pustules that resembles Pityrosporum folliculitis. We have done a study that compared proportion of Rosacea in inflamed and non-inflamed lesions. From this study, we found 120 subjects with acne had minimal 4 inflamed lesions and 4 non-inflamed lesions. We did culture and almost 65% had Rosacea. Interestingly, the Rosacea proportion that we found were in non-inflamed lesions. Need further research in this area. What is the role of zinc in acne? Zinc has the properties of anti-inflammatory agent, as we know. This article about our study of zinc serum level in acne patients, it's shown there is a statistically significant difference in mild acne and moderate severe acne group, also in zinc intake. So we still need further study to answer, do we need zinc supplements to treat acne patients? Now, how about vitamin D? We know that lots of articles reported that vitamin D status is not associated with acne. We also did our research to investigate the level of vitamin D serum in acne patients. There is no significant correlation between vitamin D level with both inflamed and non-inflamed lesions. So considering vitamin D supplementation in acne patients is still in question. Here is some take-home message from my presentation. In most of educational institutions in Indonesia, acne is still one of top 3 diseases. So we published the Acne Treatment Guideline in Indonesia. There are various kinds of adjuvant modalities for acne in Indonesia, such as Comedo Extraction, intralesion steroid injection, chemical peeling, laser, and also dermocosmetics. Not all of the adjuvant given at the same time, but we have to consider to choose what the best adjuvant that we can give and fit to each acne patient. So we still need further research in consideration for zinc and vitamin D supplementation as adjuvant therapy for acne. This is me with some E-Asia Derma speakers. This is with Prof. Go in San Diego, 2012, and Prof. Su in Madrid 2 years ago, Prof. Jerry Tan and Henry Fong in Boston 3 years ago, Peach Rao 2 years ago. We met in Jakarta, and then my boss, Dr. Wawan in Bandung. Thank you and see you again.
Thank you, Irma. I like best the pictures that you showed at the end. Nice to see friends. Dr. Su, Professor
Yes.
Su,
Okay.
okay. Can you please introduce our
Yes.
next speaker?
Okay. Can you hear me?
Yes.
Okay, yeah. Next speaker is Dr. Peach Rao. Probably you know very well that she is an excellent moderator. As you have seen her today, she is the immediate past president of the Philippine Dermatological Society, and she is now the head laser unit of the Department of Dermatology of the DOH Tondo Medical Center. She has been invited to many international conferences, and she has many publications about cosmetic dermatology and acne. So today, her lecture title is Rosacea, What's New in Classification and the Topical Regimen, Topical Treatment. Okay, let's start the lecture of Dr. Peach Rao.
Good afternoon, everyone. My second lecture is about rosacea, what's new in classification and topical treatment. What is rosacea? Rosacea is a chronic inflammatory skin disease characterized by recurrent episodes of facial flushing, erythema, papules, pustules, and telangiectasias on the central face with possible ocular and phymatous involvement. It affects between 0.9% and 10% of the population. Onset usually occurs after 30 years of age, and there is increased prevalence in women and fair-skinned individuals of European descent. Rosacea remains imperfectly understood despite its prevalence. Without gold standard laboratory markers, the diagnosis depends greatly on clinical judgment and the nomenclature used. Throughout the years, the classification schemes for rosacea have changed as clinicians and researchers study the condition. Let us look at some of the latest pathophysiology and theories on rosacea. Number one is a dysregulation of the innate and adaptive immunity, aberrant neurovascular signaling, chronic inflammation, and the overgrowth of commensal skin organisms. Second is the generation of higher levels of ROS due to an altered innate immune response in affected patients. Third is the presence of the cutaneous microbiome, including Demodex folliculorum, Bacillus oleronius, Staphylococcus epidermidis, and Cutibacterium acnes as potential players in pathogenesis. And fourth, abnormal activation of the innate immune system via toll-like receptors 2 by the cutaneous microbiome organisms. In several journals, they also found out that in the skin or in patients who had rosacea, they found a dysbiotic cutaneous and gut microbiome. The skin affected by rosacea has significantly more expression of cathelicidin, an antimicrobial peptide expressed by both leukocytes and epithelial cells. These can result in aberrant downstream effects, including leukocyte chemotaxis, vasodilation, angiogenesis, and extracellular matrix deposition. They found out that in patients with rosacea, the following were present. Demodex folliculorum was 5.7 times greater than controls. Bacillus oleronius produces antigenic proteins that potentially play a role in PPR, ETR, and ocular rosacea. S. epidermidis was detected in copious amounts in the pustular lesions of patients with rosacea. And C. acnes decreased in abundance, leading to decreased ability to acidify and emoliate the skin. At the same time, in the gut, they found that there was a high prevalence of seropositivity of H. pylori in the rosacea population. And recent studies are investigating an additional link between inflammatory bowel disease and rosacea. And patients with rosacea were 13 times more likely to have small intestinal bacterial overgrowth than control patients. And so let's go to the evolution of the rosacea classification. In recent years, there has been a theoretical change in how rosacea is viewed, with experts moving away from the subtype classification to a phenotype-based approach. This shift is largely based on the understanding that patients with rosacea usually do not exhibit one isolated symptom, but experience a combination of symptoms, such as persistent erythema with papules and pustules. Concomitantly, expert consensus indicates that multiple rosacea symptoms are best treated using a combination of treatments, which include medical therapy, skin care, and physical modalities. No definitive test exists for rosacea, and diagnosis is based on clinical observation and a patient history. When assessing treatment, experts noted that patients' perception and acceptance of their facial appearance, including its impact on their emotional, social, and professional lives, may be important in determining the level of therapy. And so now, let's look at the evolution of the subtype to the phenotype classification of rosacea. In 2002, the National Rosacea Society, or NRS, expert committee published a standardized classification scheme. Here, the diagnostic criteria was one or more of the primary features. The primary and secondary diagnostic criteria were described. The presence of one or more primary features in a central facial distribution was indicative of rosacea, and these were flashing, papules, pustules, and telangiectasias. Secondary features could occur with or independent of their primary features, and they were grouped into four main subtypes: erythematotelangiectatic, papulopustular, phimotus, and ocular, and one variant, granulomatous rosacea. Then, in 2017, the Global Rosacea Consensus, or ROSCO, the panel convened in 2016 and published in 2017 a new system now based on phenotypes. Here, the diagnostic criteria would be a persistent centrofacial erythema or phimotus changes or two or more major features. Again, the same as flushing, papules, pustules, telangiectasia, and ocular manifestations. In this new system, by the ROSCO panel, diagnostic features were changed into this, and at least two or more major features would be diagnostic. And the primary feature now included ocular manifestations. The subtypes present before and the granulomatous variant were removed. Then, in 2017, the NRS updated their criteria based on phenotype also, and it was a more robust classification compared to their 202. It was published in 2018. And this, so far, is the present classification of rosacea. Diagnostic criteria is now a fixed centrofacial erythema, phimotus changes, or two or more major features. And the criteria would now provide a timeline for transient flushing. It must occur within seconds or minutes in response to a neurovascular stimulant and state that it is characteristically prolonged. Again, these are the primary major features. And here, the granulomatous variant, which was present in their 202 classification, was already eliminated. And in 2020, the Academy also released the classification of rosacea, and it was the same as the classification in 2018 of the NRS. The only difference, not actually a difference, the only addition is that in the major features, in the ocular manifestations, they listed down these four specific findings. And so let us go to the therapeutic strategies. And I based my research as much as possible on the most recent journals that I could find. So let us go to the current treatment approaches for rosacea. Let's go to the triggers. Educate your patient. Tell them, avoid the triggers. Emphasis should be placed on avoiding irritant cosmetic products. And the use of daily sunscreen is recommended given the well-known aggravating effects of UV light. And these are the top 10 frequent rosacea triggers from the NRS survey of 1,066 cases. Sun exposure, emotional stress, hot weather, wind, exercise, alcohol, hot baths, cold weather, spicy foods, and humidity are the top 10. Then, for papules and pustules, these are the topical therapies. Ivermectin 1% cream applied twice a day, which they say is more effective than the metronidazole cream. You can have these choices: metronidazole 0.75% and 1% gel, lotion, or cream applied twice a day, and this was one of the first approved topical therapies. There's also azathioprine 15% gel or foam, also applied twice a day for 12 to 15 weeks. Sodium sulfacetamide 10% in various formulations 1 to 2 times a day, and permethrin 5% cream applied twice a day for 2 months. There are other topical therapies, but not so frequently used, such as topical erythromycin, dapsone 5% gel, benzoyl peroxide 5 with erythromycin gel or clarithromycin, and clindamycin 1% solution. Then let's go to the systemic medications. The only FDA approved is the low-dose oral tetracycline of 40 milligrams doxycycline 2 times a day for 4 to 8 weeks. You can also use minocycline, tetracycline, erythromycin, azithromycin, metronidazole, oral isotretinoin of 0.3 to 0.5 milligrams per kilogram per day for 12 to 16 weeks, zinc sulfate of 100 milligrams per day, and oral ivermectin 200 micrograms per kilogram per day. As you can see here, most of the antibiotics would be for a duration of 4 to 8 weeks. For erythema, whether flushing, transient, or persistent, the topical therapy would be alpha adrenergic receptor agonists. The first one would be brimonidine 0.33% gel, which binds selectively to the alpha-2 adrenergic receptors. This is used for patients older than 18 years old. The effect would start as early as 30 minutes. However, erythema would reappear within 9 to 12 hours. Therefore, this is for the treatment of transient and persistent facial erythema. The second alpha adrenergic receptor agonist is oxymetazoline cream 1%. This would target alpha-1 receptors. Morning application is recommended to allow for reduction of the facial erythema during the day. This is applied once a day, and this is for the treatment of persistent, non-transient facial erythema. The onset of the effect generally occurs within 1 to 3 hours from application, with a duration of effect usually observed over 8 to 10 hours, so this is longer. You can also use corticosteroids, but for short term, and topical calcineurin inhibitors. Again, for erythema, you can have your off-label use of your NSAID, antihistamines, and clonidine. You can also use non-selective beta-adrenergic blockers such as carvedilol at 3.125 to 6.25 milligrams 2 to 3 times a day. And clinical improvement in 3 weeks will be seen without the side effects of nadolol and propranolol. You can also use intradermal botulinum toxin type A. It is a promising treatment modality for facial flushing and erythema. You can use as much as about 50 to 65 units total. We all know that the release of acetylcholine leads to vasodilation of cutaneous vessels, which presents as flushing and facial erythema. Therefore, botulinum toxin A would interfere with the release of acetylcholine and would decrease the erythema. You can also use your pulse dye laser, your IPL, your 532 nanometer laser, and microfocused ultrasound and bipolar radiofrequency. For telangiectasia, the top 3 would be the 1064 Nd:YAG laser, the 595 pulse dye laser, IPL. You can also use 532 nanometer laser or the KTP, the 775 nanometer Alexandrite 1064 Nd:YAG laser, and a newer treatment is radiofrequency, which some authors have been using for rosacea. Radiofrequency, they said, was more efficacious than pulse dye laser in patients suffering from both papulopustular and telangiectasia. How about phymatous changes? Phymatous changes are due to the hypertrophy of sebaceous glands and the proliferation of blood vessels and connective tissues. Most commonly, they occur on the nose, especially on the lower third, which is referred to as rhinophyma. The systemic treatment would be the low-dose doxycycline of 40 milligrams per day and the low-dose isotretinoin of 0.3 milligrams per kilogram per day. The more effective treatment, they say, would be surgical modalities such as excision, dermabrasion, and electrocoagulation. You can also use laser ablation, such as CO2 laser and the erbium YAG laser. There are other suggested options. In patients with treatment-resistant rosacea, A combination of oral ivermectin 200 micrograms per kilo per day plus permethrin 5% cream can be considered, especially if there is Demodex species. You can combine pulse dye laser and radiofrequency with the other combinations of the topical therapies or oral therapies for resistant rosacea. With regards combination topical therapy, brimonidine 0.33 gel applied once daily in the morning and ivermectin 1% cream applied once daily in the evening, both for 12 weeks, can be effective. And of course, don't forget proper skin care. Use only gentle cleansers to prevent further abrasion and irritation of the skin, non-occlusive moisturizers, and mineral inorganic sunscreens. For your cutaneous and gut microbiome, which some say are quite dysbiotic in rosacea patients, you can make your patients drink or apply, but maybe drink, probiotics and prebiotics. And what is in the future? Erenumab, which is a calcitonin gene-related peptide receptor antagonist, and rifaximin, which is an antimicrobial. So what are my conclusions? Although there is no cure for rosacea, its features may be reduced or controlled with a range of topical and oral therapies and light devices, as well as appropriate skincare and lifestyle management. Combination therapy to target the specific features of each patient with rosacea is often necessary for effective treatment. The compilated management options which I have presented here can offer us guidelines on how to properly mix regimens depending on the presentation of your particular patient. Thank you again for listening.
Okay, Dr. Peach Rao, thank you so much for your excellent lecture.
Thank you, Professor. So now it's my turn to introduce our last, but of course not the least speaker, my co-host for this session, my co-chair for this session. Professor Dae-Hoo Soo is a professor in the Department of Dermatology at the Seoul National University College of Medicine in South Korea, the home of the K-dramas. He is also the dermatologist for the president of South Korea. He is the president of the Korean Society for Photomedicine, director of scientific and academic affairs, and council member of Korean Dermatological Association. It is my honor to introduce Professor Soo, and his lecture will be Photoelectric Therapy for Rosacea. I give you the floor, Professor.
It is my great honor to speak at the E-Asia Derma Conference. I greatly appreciate the kind invitation by Dr. Chiro Go. My lecture title is Photoelectric Therapy for Rosacea. Now I will set my headphone. The first lasers utilized for vascular regions were continuous wave argon laser and the CO2 laser. However, as vessels do not preferentially absorb the energy produced by these lasers, heat was delivered to adjacent tissues with a significant risk of scarring and pigmentation. Then, pulse dye laser PDL was developed. This photograph shows the improvement of rosacea after 5 sessions of PDL. This photograph shows the improvement of nose region after 4 sessions of V-beam, a kind of PDL. PDL was the first laser to follow the principle of selective photothermolysis for vascular regions. Now, 585 and 595 nanometer PDL is considered as the treatment of choice for telangiectasias and superficial vascular regions. At these wavelengths, PDL produces yellow light, which is observed preferentially by oxyhemoglobin to a maximum depth of 1.5 millimeter. Improvement is more evident when purpura is induced, but this purpura is really problematic. It is due to the extravasation of RBC when the very fast pulse delivery disrupts the telangiectatic as well as normal vessels. It can last up to 3 weeks and here with late hyperpigmentation, which lingers up to 4 months. To decrease purpura, laser instruments and treatment methods have been improved. For example, in recent years, scientific improvement of technology has allowed to deliver long pulse, 40 milliseconds with progressive increasing fluencies. Thermal relaxation time, TRT, of facial telangiectasia is 10 to 60 milliseconds, but the pulse duration of older standard PDL was 450 microseconds to 1 millisecond. Performing a pulse duration close to or equal to the TRT of targeted vessels can achieve more selective photothermolysis and decrease the risk of purpura. Low fluence subpulpal passes, devices that emit multiple subpulses, and the pulse stacking at lower fluences have been reported to decrease the purpura. To increase the efficacy of PDL, some interesting methods were introduced which can increase the blood flow in the treatment area. These articles reported the pretreatment with topical niacin and the use of a hair dryer. The next instrument is intense pulsed light, IPL. IPL emits non-coherent high-intensity light at wavelengths from 5 to 1300 nanometer, depending on the band pass filters. Combinations of one specific wavelength along with the pulse duration and the pulse intervals provide versatility to treat a wide range of skin disorders. Along with PDL, IPL is one of the most commonly used light-based devices to manage rosacea-related facial erythema and telangiectasia. There are several kinds of IPL, but final outcomes are quite similar. In ETR, erythematotelangiectatic type rosacea, the better IPL response is achieved in more severe disease and in younger patients. These patients received 3 sessions of IPL and showed the reduction of redness. Authors of this article used the Vigia photograph methodology to know the degree of redness. This article is from China. It shows the result which can show the significantly greater clinical erythema improvement, especially in the periregional erythema in PPR, papulopustular type rosacea. These cases show the improvement of PPR as well as ETR by IPL. Good effects of IPL in the improvement of erythema, telangiectasia, and the inflammatory regions is also demonstrated in Western rosacea patients. These patients received 4 sessions of IPL. The next is NDR laser. To be adjusted to TRT, thermal relaxation time of blood vessel, long pulse 532 NDR laser was developed. It was effective for facial telangiectasia, but it could not reach deeper vessel due to short wavelengths. So currently, the most popular NDR laser for telangiectasia is long pulsed 1064 nanometer Nd:YAG laser. With this wavelength, this long wavelength, Nd:YAG laser penetrates up to 4 to 6 millimeter, and it is particularly useful for vessels located deeper in the subcutaneous tissue. The absorption of energy by hemoglobin at this wavelength is relatively low, while water absorbs much more energy. Thus, higher fluencies are required to destroy blood vessels. For example, 40 to 50 joule per square centimeter with a pulse duration of 50 milliseconds is used. Destructions of telangiectasias concomitantly produces non-selective bulk heating, and in turn, it results in dermal rejuvenation and the reduction of wrinkles. This laser is also effective on PPR, papulopustular rosacea. This article is from South Korea. Laser removes the follicular units affected by Demodex mites, which are responsible for inducing perifollicular inflammation in PPR. This laser has also been reported to be effective for inflammatory regions in hidradenitis suppurativa. Modulation of immune response has been also suggested as one of the mechanisms. These two PPR patients, severe and moderate, were improved by 3 sessions of long pulse Nd:YAG laser. It has been suggested that combining multiple wavelengths can provide further benefits while lowering the risk of purpura. For example, there are laser platforms which allow 532, 585, 595 nanometer PDL, and 1064 nanometer Nd:YAG laser to be emitted in sequential way from the same handpiece. These dual systems are based on the fact that PDL-heated blood vessels exhibit increased absorption of energy at 1064 nanometer. This may be due to the genesis of methemoglobin after the first pulse of PDL. At subpupillary levels, lower wavelengths induce the formation of methemoglobin, which is known for its higher absorption in the near-infrared spectrum. Recently, 577 nanometer pro-yellow laser was added to the armamentarium of rosacea treatment. The reports using this laser are rare until now, but it is promising because it has excellent effects in facial erythema and facial telangiectasia. One of the big advantages seems to be its safety. No side effect was observed except for a few patients who had mild to moderate erythema. Potassium titanyl phosphate Ktp laser is essentially a type of Nd:YAG laser that emits green light with half wavelengths and enhanced or double the frequency. Due to short wavelengths, the delivered energy penetrates slightly. Hence, the Ktp is particularly effective for superficial thin telangiectasias and erythema. Unlike PDL, Ktp has a low risk of purpura because Ktp has a longer pulse duration. This is the advantage. However, Ktp is more likely to induce PIH in darker skin. Furthermore, compared to PDL, Ktp may cause more edema, swelling, and post-laser erythema. So Ktp is much less frequently used in rosacea treatment, especially in South Korea. This table shows the effect of devices on each type of rosacea region. For thin and superficial telangiectasia, PDL and IPL work much better than other devices, while NDR laser is more effective for thick and deep telangiectasias. They may be also useful for background erythema and papules and pustules. My lecture title is Photoelectric Therapy of Rosacea. So I will talk about electric therapy, and one of them is fractional microneedling radiofrequency, FMR. FMR delivers bipolar radiofrequency directly to the dermis with an array of microneedles, so that there is no electrothermal epidermal damage and no cooling is required. And a linear zone of precise coagulated dermal tissue remains at the preset depths. First, we used FMR for acne scar treatment. This 21-year-old female shows good effect of FMR for acne scar. Then we found the redness around the acne scar was improved simultaneously. So after IRB approval, we studied FMR treatment for acne-related post-inflammatory erythema, and it was published in Acta Dermatovenerologica. In this study, we performed skin biopsy before and after treatment, inflammation on H&E staining, and basal proliferation on alpha SMA staining were much decreased in FMR treated group compared to control group. Significant difference of BGF, NF-kappa B, and the interleukin 8 intensity after the second session of treatment was noted compared with the control group. So we hypothesized that FMR may make an effect on rosacea by the same mechanism. And we performed a study, clinical and histological effect of FMR treatment on rosacea. It was published in Dermatologic Surgery. It was a 12-week prospective randomized split-phase clinical trial. One side of the cheek was treated with FMR and the other side remained untreated. And each patient received 2 sessions of treatment with a 4-week interval. And we performed the skin biopsy. We used the derma spectrometer and the spectrophotometer, and the subjective assessment of rosacea symptom and the immunohistochemical staining were performed. Erythema index measured by spectrophotometer, by derma spectrometer, and A value by spectrophotometer was significantly decreased after treatment in the treated side compared with the baseline and untreated side. Erythema index and A value decreased at week 12 compared with baseline 13.6% and 6.8% respectively. And FMR and A value were more significantly decreased in PPR type compared with ETR type, 10.645% versus 4.9%. Subjective improvement in view of therapeutic effectiveness, satisfaction score, and rosacea symptoms were also noted. This case shows the improvement of rosacea by FMR treatment, treated side and untreated side. We performed the skin biopsy before and after treatment, and it showed the decreased overall dermal inflammation and mast cell counts. Immunohistochemistry showed overall decrease of markers related to angiogenesis, inflammation, innate immunity, and neuronal cation channels. Compared with the untreated side, all the markers except toll-like receptor 2 and TRPV3 was significantly reduced in the tissue from the treated side. This figure shows the possible mechanism of FMR treatment. FMR may regulate inflammation and angiogenesis. In addition, heat produced by FMR could potentially kill mites or bacteria, resulting in the suppression of the overactivated innate immune system. FMR may affect mast cell in number and function. So we concluded that this FMR might be used as an alternative or in combination with other treatment methods in rosacea. Then I would like to mention gold photothermal therapy, gold PTT. PTT is a therapeutic method whereby cancers are ablated by the heat generated from observed near-infrared light energy. Topically applied gold-coated silica microparticles followed by laser exposure leads to photothermal disruption of the infundibular sebaceous unit without collateral damage to adjacent skin. And ultrasound enhances the penetration of nanoshells. In recently published article, these cases shows a significant improvement of PPR type rosacea, papules and pustules after 4 sessions of gold PPT, and further improvement was observed during the follow-up period of 3 months after the treatment. Lastly, I will mention PDT, which has been used for more than 15 years in rosacea treatment, before treatment and 9 months after treatment. Recently, a Chinese group reported good effect of PDT. They investigated 17 rosacea patients. They were treated 3 times using ALA PDT at intervals of 7 to 10 days, and the total effective rate was 65%. These photographs shows the effectiveness of PDT before treatment, 1 month after 3 treatment, 3 months after 3 treatment, and 3 months after 6 treatment. In conclusion, there are various kinds of photoelectric therapy, and they may be used in ETR type as well as PPR type rosacea. One important benefit of device treatment for rosacea is that the therapeutic effects are generally seen over a limited number of treatment sessions, which are in contrast to the need for daily treatment over extended periods of time with topical or oral medication. Once an endpoint of an acceptable therapeutic effect is achieved, the results may be maintained for a long time. I always appreciate the work by my research associates, dermatology residents, and the students. Thank you so much for your attention.
Thank you, Professor Su. Very nice lecture on lasers and energy-based devices. So now we can go to the question and answer. There are several questions that have come in. Professor?
Yes.
Yes, would you like to read the question for Dr. Irma and Dr. Gold?
There is one question for Dr. Irma. It is from Dr. David Ng Cho Phua, maybe from Vietnam. Hi, Dr. Irma. For your procedure of acne region extractions, which seems quite painful, what types of anesthesia do you use for your patients?
Yeah, thank you, Prof. Su. Can you hear me?
Yes,
yes,
we can hear you.
Yeah, thank you, Prof. Su. Thank you, Dr. David Cho Hua, for your question. Actually, there is not quite painful, maybe a little bit painful. Mostly acne patient can overcome the pain, so no need anesthesia for these procedures. We did the tiny prick incision first before the procedure at the beginning on the top of lesions with maybe with 26 gauze needles, and it should be made because it could be decreasing the pain. This procedure is the most frequent procedure as adjuvant treatment that we gave to the patient in our department. We did to both in non-inflammatory acne and non-inflammatory lesion. So after 2 weeks, 2 weeks later or 4 weeks later, the patient came again, and we facing rapid resolution and marked improvement. So this procedure increased our patient satisfaction. Thank you.
Okay, thank you for your answer. And
Dr.
there is one question.
Dr.
Okay.
Michael Gold, can you open your video there? Thank you.
Okay, yeah. There is one question for Dr. Gold. It is from Dr. Nur Ashkin Ahmad. The question is, what will be your choice for adjunctive energy-based modality for comedonal acne and papulopustular acne?
Yeah, I mean, in today's world, you know, in my clinic, we mainly use the short pulse 1064 for acne, and it has advantages, at least the one I use. It's contactless and touchless, and there's no disposable. So I like the no disposable part of all devices when I can get them. And the fact that it's contactless, especially during this period of the last year and a half, is very good. And so, so we use the short pulse 1064 with our topical medicines, our oral medicines, but in reality, you can use IPL, you can use whatever device you're comfortable with. They all work. And so, as I said in the other session, when we do the clinical work, like what you all have done, we do it as monotherapy. In the real world, we use combination therapy for everything.
Okay, thank you so much for your answer. I totally agree with you.
Me too. You know, I have a little addition for Irma. Sometimes there are patients who are really very sensitive. Like, it's not really painful, I agree with you, but for them, it's horribly painful. So sometimes if you have the time, like for myself, I put a topical anesthesia just before the procedure for about 30 minutes. And then it becomes a little more tolerable procedure. But these are only maybe for the younger patients, or the very uncooperative, or the pain tolerance is really quite impossible to understand.
Okay, yeah. Thank you, Peach Rao.
Okay, there are two questions for myself. One is, how long is the effect of intradermal botulinum toxin on erythema? Well, I haven't really tried this yet, but I usually do a lot of intradermal botulinum toxin for other conditions. And usually they last for about 3 months. So I suppose the same would be for rosacea. You can do this just to prevent the flushing, and I guess get an effect of about 3 months, and then maybe you can repeat, and usually do this in combination. I always suggest combination treatment for rosacea, not monotherapy, just so you shorten the treatment and you make the treatment more effective. And then the other one is, can you use, oh, this is from the same doctor, Dr. Nguyen T. Tu Trang from Vietnam. Can use ivermectin and permethrin oral and topical for long-term use. For the oral, I think I will stick to about 8, maximum would be 12 weeks for oral. Topical, I can probably extend. And then if the patient would improve, decrease the frequency, maybe make it pulse treatment, or give up one and just leave the other one. And again, combination treatment. But for oral, I wouldn't probably go for 6 months. Maybe maximum would be about 3 months. But I can extend the topical. Anybody can disagree with me on this one? Okay, and And how about Professor? How would you treat your oral and topical permethrin and ivermectin for rosacea patients?
We launched topical ivermectin about 2 years ago. So now I'm using it for mainly pustular type rosacea, and the effectiveness is different according to the patients, but usually it works well. But for very severe rosacea, we should also use some oral agent, oral tetracycline or minocycline or doxycycline. So oral ivermectin is not available for human in South Korea. So that is the situation in South Korea.
I would like to ask Dr. Gold, because there are no questions coming in yet. Like in very, very, let's say, flaring, very active acne or very pustular rosacea, would you still do immediately 1064 laser on your patients? Or would you let them subside a little bit?
So when I first started with these devices, I would always want to start with medicines first and see if I can reduce the inflammation in some degree. But reality is today, I use if the patient is ready to have the devices, I'll start on day one. And I think what Dr. Su showed with the fractional microneedling RF, that's actually become something that we do a lot because of the radio frequency, we can coagulate vessels. We can do a lot with this that actually calms the inflammation down very quickly. So I think that if you have devices, I mean, I think that the difference that I live in, and I'm sure it's similar in most parts of wherever, I live in a cash and an insurance-based world for acne and rosacea. So acne and rosacea medicines are covered by insurance. Devices are strictly cash-based. And so you have to put that in, that's a reality in the world for me. And so the devices are sometimes not used on day one because patients need to plan for that. They need to save their money or whatever, because that's cash-based. Yes. However, if we can do it, I like doing it immediately now.
Okay. Very good practical point of view.
Yes. Irma, what would be your suggestion for probably the best combination of adjuvant treatment for your acne patients?
Okay. It depends on the grade of acne and acne lesion, various of acne lesion. So we will do the acne lesion extraction for all the acne lesion. And we will do the V-beam laser or pulse dye laser for if there is erythema is prominent. So not all of the adjuvant treatment that we give to the patient, but we have to choose what adjuvant treatment that fit to the acne lesion in that patient.
Agree.
Yeah.
So I guess we all agree that this is now the generation and the time of the combination treatment.
Yes.
So everything now we do is in combination. I think we all agree on that.
Yeah.
Okay.
We agree on that.
Professor, I think we have to wrap up soon, unless I think we have 2 minutes, unless another question comes up, which I don't see now. Any closing remarks from our speakers? Any key messages?
There were very excellent lectures in this session. So I think that the audience enjoyed our lectures. And I really hope that we can meet face-to-face in the near future after recovering from COVID-19 situation.
It's the hope of everyone.
Yeah.
Dr. Gold, looks like your 1064 short pulse really also is a workhorse for a lot of conditions. Yes.
It is.
And-
Yes, very much so.
Thank you.
Irma, it's so
Yeah.
nice to see you.
Nice to meet you. Nice to see you again.
Yeah, nice
Prof.
to meet you
Su,
again.
nice to meet you again, Prof.
Irma,
Su.
nice to meet
Prof.
you.
Go. Thank you, Prof.
Professor
Go.
Go.
Prof.
Thank you
Go.
very much for
Michael
everything.
Go.
Okay,
See,
so
we'll see you soon.
See you
See you
soon. I
soon.
think Dr. Go
Yeah,
will have
see
to
you
go and
soon.
sleep now.
I'll go back to sleep.
you go back to
Sleep, yeah.
See you in Singapore in
Yes.
2023 WCD.
Yeah,
Yes,
I
yes.
hope so.
That's right.
Yeah.
WCD.
Yeah.
Oh, we
Yeah,
also
Everybody can come.
don't forget, we also have the Regional Congress of Dermatology, and Manila is the host in 2022. It's a virtual conference, so we will bring out the invitations to
Yeah.
everyone very soon.
Yeah.
So,
Yes.
on behalf of my co-chair, Professor Su, our esteemed speakers from the beginning of the first session until the second session, and presently Dr. Gold and Dr. Irma and Prof. Go, we would like to close the section on acne scars, and rosacea. We hope you enjoyed our session. Thank you very much.
Thank
And
you.
Thank you.
see you.